Hello, I'm Judith Auerbach. I'm a sociologist working as an independent consultant and as adjunct professor in the School of Medicine at the University of California, San Francisco. I've been working at the nexus of science and policy in the realm of HIV for about 30 years in academia, government, and non-governmental organizations. One of my focus areas is advancing evidence-based and data-driven HIV prevention. I'm particularly committed to facilitating and promoting multidisciplinary and multi-sectoral approaches that combine various types of evidence and ways of knowing. What is most relevant for this presentation is that I am one of the guest editors, along with James Hargreaves, Bernadette Henson, and Simon Gregson, of the just-released Journal of the International AIDS Society Special Supplement on Data-Driven HIV Prevention, the HIV Prevention Cascade, and beyond. Today, I'm going to introduce some issues that are elaborated in that volume and that are meant to provoke further conversation. I'd like to thank Brian Rice, James Hargreaves, Flora Stevens, and the MeSH Consortium for inviting me to make this presentation. Now that we are in the midpoint of 2020 and are in the early surge of a new pandemic of COVID-19, it's clear that the global goals and targets set by the UN for reducing new HIV infections to fewer than 500,000 per year by 2020 and ensuring that at least 90% of people at risk for HIV have access to combination prevention options by 2020 will not be met. Moreover, while some progress in reducing new HIV infections has been made in some settings through universal test and treat programs, we've learned from our 4 decades of HIV that we cannot treat our way out of epidemics. Treatment is necessary but not sufficient for HIV elimination. That will only happen through widespread prevention of HIV acquisition. Great hope remains for a vaccine, of course, but we still don't have one. At the same time, we do have a range of primary prevention tools already shown to be efficacious. To achieve effectiveness and to see significant progress in reducing new HIV infections, it's essential to ensure that these tools are being delivered with high quality and sufficient intensity and scale and taken up and used consistently by the people who most need them and want them. The only way we can know that this is happening is to measure it and collect and use data in a systematic way. Yet currently there is no standard method for doing so in HIV primary prevention. And as a result, it's always difficult to know how well we really are doing. To redress this and to promote data-driven HIV prevention programming, many are proposing the adoption of a cascade approach, parallel to the now standard treatment cascade. But this has proven to be a controversial enterprise, chiefly due to the complexity of primary prevention. So why prevention cascades? What would be their value? Prevention cascades potentially have multiple and somewhat overlapping uses. They can provide a logical framework summarizing actions taken by individuals across a population that can prevent HIV acquisition. They can be a management tool to focus on gaps, barriers, and bottlenecks that are revealed by the cascade and to identify potential for programmatic improvement. And they can be used as an advocacy tool for indicating points for intervention to enhance program effectiveness and ultimately contribute to the reduction of new HIV infections. Notwithstanding their potential value, a number of core issues and nuances have made it very difficult to reach consensus in the field about how to devise HIV prevention cascades and to agree on one shared model. Let's look at just a few of these. First is the question of the initial denominator, the first step in the cascade. Determining the beginning denominator, the population of interest, in an HIV prevention cascade can be challenging. For HIV prevention, there is no uniform, clearly defined population in need, as compared with, say, the treatment cascade, where it is all people living with HIV, but rather several populations that have different characteristics and vulnerabilities to HIV infection. Moreover, HIV prevention is neither a uniform nor a linear process. People move in and out of situations of risk affected by a range of psychosocial, interpersonal, demographic, and environmental factors. This also means that within populations that are defined as at risk because of their overall HIV incidence or prevalence, for example, female sex workers or people who inject drugs, there is heterogeneity of risk. As with any group categorized according to epidemiological risk factors, there is an averaging of risk across heterogeneous population. So in choosing a population focus, there's a trade-off between the level of risk and the number of people covered. Additionally, although primary prevention cascades focus on those who are HIV negative, many HIV prevention programs do not begin with HIV testing to determine who definitely is uninfected in order to focus the promotion of primary prevention methods on them. In some cases, prevention programs are even intentionally delivered to a population that includes both HIV uninfected and HIV infected individuals with a specific type of risk for either transmission or acquisition. For example, all people with non-regular partners for whom condoms would be recommended, which can complicate the denominator. A second issue relates to the fact that we have multiple prevention options. People at risk of HIV often are presented with more than one option of prevention, unlike the fairly singular antiretroviral therapy option that is monitored through the treatment cascade. Sometimes prevention method options are delivered simultaneously in a package, for example, one that promotes condoms and pre-exposure prophylaxis and provides economic support for adolescent girls and young women. Measuring the effect of a prevention package as a whole, while desirable, becomes very tricky. The prevention package can be thought of as the set of activities undertaken to ensure that prevention methods are effectively used, and cascades can be devised for each component prevention method in the package. Looking at the combined cascades generated by a prevention package allows the effectiveness of the package to be assessed. These realities of prevention programming mean that multiple differentiated prevention cascades by population and prevention method are necessary. These can follow a uniform framework, but their characteristics and data points will be different. A third issue is the final outcome, that is, the last step in the cascade. Deciding what exactly is and should be the ending point, the measured and reported outcome for prevention cascades, fundamentally depends on the purpose of the cascade. If the focus is on program coverage and the uptake and use of prevention methods promoted by that program, then the endpoint would be achieved correct and consistent use, otherwise known as adherence or persistence of the prevention method. If the focus is on evaluating the impact of the program on HIV infection rates, that is, incidence, then the endpoint would be remained HIV negative. The latter is much more difficult to measure directly in a cascade model, as it requires a combination of program data, behavioral surveys or interviews, and repeated HIV testing. But it can be based on estimates of efficacy when correct and consistent use is known. And by the way, this is similar to the treatment cascade where viral suppression is used as the final outcome, not decreased morbidity, mortality, and/or onward transmission, although these can be estimated from what is known about the efficacy of viral suppression. Where capacity exists, researchers can work with program implementers to estimate infections averted through mathematical modeling of the acquisition and transmission of HIV and the population dynamics of infections, and other extrapolation methods. Well, these and other issues will surely continue to be debated, but meanwhile, there is a strong sentiment, particularly from HIV prevention program managers at national and subnational levels, and from government and non-governmental organizations who are involved in the implementation, administration, monitoring, and evaluation of HIV prevention programs, that they would benefit from having a standardized cascade model, like the treatment cascade, to monitor and report their progress and to identify gaps and opportunities for improvement. The advantage of a relatively simple, generic model is that it promotes comparability over time, across populations, between subgroups of a population or across geographic areas, and between prevention methods. At this point, two standard models have been proposed in the field, in the literature. One developed from UNAIDS-led consultations and currently under review as a potential guidance to the field, that is fairly basic and is intended as a program management tool. It effectively describes the what of HIV prevention, what is being provided and used by a given population, and can help determine gaps for the purposes of informing program improvement. This basic cascade model can be populated with available program and survey data. The other cascade model, developed by a number of MeSH-affiliated colleagues, extends the basic framework to get at the why of the prevention gaps by identifying individual motivations and structural causes. This requires the additional collection of qualitative and quantitative data that can then inform the development and testing of appropriate solutions to improve the effectiveness of HIV prevention efforts. Both of these cascade models begin with identification and quantification of a focus population group and include subsequent steps related to the reach or coverage of a prevention method and its uptake and use by that population. Neither includes an HIV incidence outcome measure for the reasons mentioned earlier. However, if one wanted to draw the cascade out further, a program's impact on HIV incidence could be assessed through mathematical modeling and other extrapolation methods, as I just mentioned. In the end, the prevention cascade is chiefly a heuristic device, but programmatic and policy decisions will be made from it, as has been seen with the experience of the treatment cascade. So what goes into the cascade model is key. A prevention cascade will only be as good as the data that comprise it. Since most data are not perfect, neither will be the prevention cascade. What is most important is to use the best available data and to be clear about their sources, quality, and limitations while continuing to find ways to improve them, and then to use these data to inform decisions about programs. Many of the papers in the new supplement of JIAS on data-driven HIV prevention attempt to operationalize an HIV prevention cascade, using one of the two models I've just described or innovating their own. Their settings include numerous countries in Africa, as well as Thailand, Ukraine, and the United States. Their populations include adolescent girls and young women, female sex workers, gay and other men who have sex with men, transgender persons, pregnant mothers, and people who inject drugs. And their prevention methods include HIV testing, including self-testing, condoms, PrEP, and sterile syringes. All grapple with the issues I've mentioned, but most find the cascade approach allows them to use existing data to reveal gaps, barriers, and opportunities that point the way to programmatic improvements for specific populations. And they underscore the need for ongoing innovation in data collection that is feasible in different settings and that would improve the validity and utility of the cascades that can be generated. We are about to enter the 5th decade of HIV and AIDS in the context of a new pandemic that has the potential to undermine our HIV prevention efforts. Whether or not we reach normative goals in 2020, 2030, or even 2050 may become less significant than knowing we are doing the best we can to provide the right HIV prevention services to populations most in need, now under very difficult circumstances. And we can only know this if we measure it. Thank you.